Hi, you're all welcome to Critical Care. Today I'm going to teach you advanced cardiac life support treatment algorithm. My special thanks is belong to Dr. Hani Samwar, Al Sifa Medical Complex. I think it is in Palestine. This presentation is belong to them. I'm just going to present it for you. Actually, today I'm going to present you about basic life support, not about the advanced cardiac life support. I'm 100% sure after knowing about the basic life support, you will be keen to learn about advanced life support as well. Before moving to advanced life support, can anyone tell me what is resuscitation? What do you understand by the term of resuscitation? If you found a patient with low blood pressure, you decided to give fluid for that patient. That is kind of resuscitation. If you found a patient with hypoxia or low level of oxygen, you decided to give oxygen for that patient. That is a kind of resuscitation. Resuscitation is the process of correcting physiological disorder in an acutely ill patient. So, all your intensive care patients, trauma patients, surgical patients, emergency medicine patients need some kind of resuscitation. One of the world famous resuscitation is called cardiopulmonary resuscitation. I am 100% sure all the doctors in the world know about cardiopulmonary resuscitation, at least the term of cardiopulmonary resuscitation. First of all, if you found a patient, how are you going to decide your patient needs resuscitation? Your patient needs some kind of resuscitation. For that, you have to have systematic approach. First of all, you have to talk to your patient. Hi Harry. Your patient says, yes doctor. That means your patient is conscious. If your patient is conscious, if you want to identify whether your patient needs resuscitation, you have to go through the primary survey and secondary survey in order to identify any physiological derangement. There are some kind of patients not responding. You say, hi Harry, hi, not respond at all. That kind of patient may need basic life support, followed by primary survey and secondary survey for the resuscitation. I will tell you later how I am going to do that. First of all, what is BLS? BLS stands for basic life support. If you found a patient with unconscious, collapsed patient, what are you going to do? Are you going to jump and resuscitate your patient? No. Sometimes that patient might be electrocuted patient, still wire in hand. If you jump, you also electrocute. Sometimes your patient burning. If you jump, you are also burning. Then your staff have to resuscitate two persons, you and your patients both. So first of all, you have to think about your safety. One should ensure your safety. Check for the responsiveness. Hi Harry, check for the responsiveness. Then activate emergency response. This is room number 231. This patient is not responding and collapse. Please come immediately. You have to activate emergency response. Then check for the pulse and breathing. Whether your patient breathing, whether your patient having pulse. Then you have to start CPR. That is how you are going to approach unconscious patients. If you found a conscious patient, I already told you about, you have to start with primary survey. Conscious, critically ill patients. First of all, you have to assess the airway. If your patient is talking, that means airway is patent. If your patient is not talking or sound is some kind of struggling, the airway might not be competent at all, or sometimes partially competent. In that case, you have to open the airway. For that, you may have to use basic airway management or advanced airway management. After correcting the airway, you have to check for the breathing, whether your patient breathing or not. If breathing, adequately ventilating and adequately oxygenation, you have to ensure that in the breathing part. After that, you have to check the circulation. For that, vital signs, pulse, blood pressure, capillary leak type, you have to check. You have to check for the abdomen, for the free fluid. You have to examine the pelvis as well. Not only that, you have to do the fast scan. What does it stand for fast? Fast means focus, assessment, sonography in trauma. You are going to ultrasonically examine for free fluid in the abdomen and chest. Free fluid in the abdomen mainly. After that, you have to check for the disability. After that, you have to check for the disability. For that, you have to check for the GCS, Glasgow Eye Scale, ABPU scale. What is stand for ABPU? A mean alertness. Patient already alert. V mean patient alert, but only to the verbal command. Harry, Harry, yes doctor. Yes doctor. Only to the verbal command. Harry, Harry, not respond, but pain, patient respond. That is mean P. Response to pain. U mean unresponsive at all. AVPU, alert, verbal, pain, unresponsiveness. Then you have to check for the pupils, whether it is pinpoint or whether it is fixed and dilated. Then you have to expose your patients. Sometimes there can be huge laceration in the back and bleeding continuously. Your resuscitation from front with the fluid, the blood going from the back, your resuscitation will not be successful. For that, you have to expose your patients. Once you complete primary survey, you have to go for the secondary survey. Do you want to know what is secondary survey? In secondary survey, the first thing is you have to check for the signs and symptoms. You have to check for the suspected disease sign and symptom. Meanwhile, you have to take the history. Do you have any allergy? Are you on any medication right now? Do you have any past medical history, or are you suffering from any medical diseases? Any diseases? When did you have your last meal? What happened? What is the event leading to this condition? You have to take that history. That history is called ample history. Allergy, medication, past medical history, last meal and event leading to trauma. Ample history. That is how you are going to manage conscious patient. Primary survey followed by secondary survey. If you found an unconscious patient, what are you going to do? Patient is unresponsive. First of all, you have to open the airway. First of all, you have to open the airway. For that, you can use chin lift, jaw thrust, and head tilt. Once you do those three things, most of the time airway will be patent. Most of the time airway will be patent. Jaw thrust, chin lift, and head tilt, airway open. Then keep your ear close to the patient nose. Then you can feel the airflow and you can listen to the airflow. And while you palpating the carotid pulse, look for the chest expansion. Look for the chest expansion. If it is expanding and pulse is there, you no need to do anything. You have to put your patient in the recovery position. If those are not there, that means not a breathing and no pulse. Then you have to start CPR. Let's see how we are going to start that. If you found a patient with cardio and respiratory arrest, you now confirmed it. No pulse, that means cardiac arrest. No respiration, that means respiratory arrest. Simply means cardiorespiratory arrest. You have to give a call for resuscitation team immediately. There is a cardiorespiratory arrest. Please come into room number 231. Please come into room number 231. Then you have to immediately start CPR. Then you have to immediately start cardiopulmonary resuscitation, also called CPR. High quality chest compression followed by rescue breath. Chest compression 30 followed by rescue breath. 2 rescue breath until defibrillator or monitor attached. You have to give high quality chest compression. Why high quality chest compression? Otherwise, your resuscitation process will be unsuccessful. You have to push hard and fast. You should have high bicep and high body weight in order to achieve success resuscitation. Your rate of chest compression should be 100 to 120 compression per minute. 100 to 120 compression per minute, and the chest compression width or depth must be approximately 5 to 6 centimeter, that means 2 to 2.4 inches when coming to adult. When coming to pediatric population, one third of the depth of the chest in children and infant. One third. When coming to adult, 5 to 6 centimeter. Can you press your own chest 5 to 6 centimeter? It is so difficult. When coming to resuscitation also, it is so difficult. Some people keeping compression without allowing to chest to recoil. That is so bad. Why? Once you allow to chest to recoil, it creates relatively negative pressure in your chest. When you compress, there is positive pressure within the chest cavity. Once you allow to recoil, there will be relatively negative pressure in your chest cavity. That will aid venous return from superior vena cava and inferior vena cava. That will facilitate venous return and it will success your resuscitation. So you should allow chest to recoil. Don't keep in compression. Allow it to recoil and compress. Allow it to recoil and compress. Allow it to recoil and compress. Meanwhile, you should avoid hyperventilation. Here we are giving positive pressure ventilation. It will negatively affect the venous return. If you create positive pressure in the chest cavity, do you think venous blood easily can come into chest and heart? No, it will negatively affect. Therefore, you should avoid hyperventilation. You should avoid hyperventilation and you should minimize interruption. You should minimize interruption of the CPR. You should have continuous CPR in order to success resuscitation. This is how you are going to give CPR to your patients. So, when coming to airway ventilation technique during CPR, initial method is usually bag and mask ventilation with supplement oxygen. If you think airway is not patent, you can use oropharyngeal or nasopharyngeal airway in order to make them more patent. 2 positive pressure breath after every 30 chest compressions. 25, 26, 27, 28, 29, 30. Then you are going to start 2 positive pressure breath. 1 second for inspiration, then release. 1 second for inspiration, then release. While giving that breath, look for chest, the visible chest wall rise. If it is not there, sometime your breath might not be success. Are you going to give another breath then? You give 2 breaths, 1 success, 1 fail. Are you going to give another breath? No, you have to wait for another cycle. During that period, you have to use some airway adjunct in order to make airway more patent. This time I will give proper breath, proper chest rising 2 breath. You have to ensure that. If your patient have advanced airway in place, advanced airway means LMA, laryngeal mask airway or endotracheal intubation. You have to ventilate at a rate of 8 to 10 per minute, not more than that. If you do more and more, it will reduce the venous return. If you do less, it will improve the oxygenation. So you have to do at 8 to 10 breath per minute. And chest compression 100 to 120 per minute. There is no correlation between 2 now. Initially 30 plus 2 breath, 30 plus stop 2 breath, 30 plus stop 2 breath initially. Once your airway in place, chest compression continuously going while I'm doing. I can't do 2 simultaneously, but both 2 should go simultaneously. Respiratory rate 10 per minute and chest compression 100 to 120 per minute. Your patient somehow gained the circulation, pulse is there, but no respiration. Then what are you going to do? Then you have to give breath 1 in every 6 seconds. 1 in every 6 seconds. That means again 10 per minute. You have to manually ventilate. You do not need to give cardiac chest compression because your patient now gaining the circulation but still not getting the respiration. In that case, you have to give respiration, no need to give chest compressions. So, shall we meet in the next part? In that part, I am going to teach you how it is different from the pediatric population and adult populations. And not only that, advanced life support as well. Bye bye.